Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 52nd virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Foot Pain? Early Detection is Key, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Everyone suffers with aching feet from time to time. When the ache becomes problematic and begins to affect your everyday life, it is time to get a proper diagnosis and see what can be done for your foot pain. Tonight, Douglas Solway, DPM, is here to talk to us and talk us through some of the common causes and triggers of forefoot pain. Hopefully, he'll answer your questions about your aching feet during his presentation this evening. Dr. Solway is board certified in podiatric medicine, practicing in IBJI's Morton Grove, Des Plaines, Highland Park, and Buffalo Grove locations. He's been in practice since 1994, that is 30 years, and earned his DPM at Dr. William M. Scholl College of Podiatric Medicine. As a child, Dr. Solway was hospitalized repeatedly for treatments for clubfoot and asthma. His gratitude and admiration for the physicians who treated him, combined with his desire to help others, made him decide to become a doctor. He chose to specialize in podiatry because it gives him the opportunity to focus on both his interest in orthopedics and in plastic surgery. Specializing primarily in conditions affecting the foot and ankle, Dr. Solway offers state-of-the-art treatments such as regenerative therapy using platelet-rich plasma, also known as PRP therapy, musculoskeletal ultrasound with guided injections, wound care using advanced biologics, and reconstructive surgery using modern implants and cutting-edge technologies. In addition, his areas of expertise include diabetic foot care, heel pain, fracture care of the foot and ankle ligament repair and fusion, bunions and hammer toes, tendon repair, orthotics and arch supports, plantar fasciitis, and independent medical evaluations. If you ask Dr. Solway about his patient philosophy, he'll tell you that he believes in treating his patients both physically and emotionally. In listening carefully to his patients, he can learn their whole story, and ultimately, patients will tell him what he needs to know to discover the most accurate diagnosis. After determining the course of treatment that will achieve the speediest recovery for each individual case, Dr. Solway then works with his patients to educate them about their conditions and treatment options so that they can ultimately be comfortable and satisfied with their treatment plan. In Dr. Solway's 30 years of experience, he served for 9 years as team physician for the Chicago Bulls, including the last 2 championship seasons, and 9 years with the Chicago Wolves hockey team. Currently, he heads the IBJI Morton Grove Wound Care Clinic. If you're looking for a podiatric doctor with experience, you need look no further. During Dr. Solway's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Solway immediately following his presentation. I do ask that you please keep your questions general, as Dr. Solway will not be able to address individual concerns without individual consultation. If you do have self-specific questions, however, please contact Dr. Solway via one of the options that will be listed on the slide shown during the Q&A portion of our program at the end of his presentation. One last thing before I turn the evening over to Dr. Solway, please mark your calendar for our next IBJI and YMCA Education Series program on Wednesday, June 26th at 7 p.m. Dr. Brian Schwartz will discuss enhancing hip health to help us discover strategies for optimal hip health and hip function. Thank you again for joining us tonight, and thank you, Dr. Douglas Solway, for your time and effort in putting together this program to help us learn about how early detection is key to understanding and treating our foot pain. Dr. Solway, please take it from here.
Thank you very much.
You bet.
Okay, so I want to thank everybody for showing up tonight. Hopefully we'll be able to educate you regarding a very common condition that I see very often throughout the week at my office locations. Today we're going to be talking about something called pre-dislocation syndrome. And this is something that I actually was involved when I was with the Bulls, where we went ahead and found that a lot of players were having problems with their forefoot pain, and a lot of pretty well-known players ended up having surgery. So this is something that probably came up around the 1990s, late 90s, and early 2000s. So we're going to kind of go in depth. First, we're going to talk a little bit about common foot issues or foot facts. Basically, the human foot has 26 bones, 33 joints, and 100 tendons, ligaments, and muscles. So it's a very complex part of the anatomy. And that's why it's pretty amazing to me, because people walk every day. We use our feet just like as if you were driving a car. As the car gets older, things break down. Same thing happens to humans, and as we walk, things happen to our feet. The average person walks 115,000 miles by the time they are 80 years old. That's approximately 4.25 times around the globe at the equator. Average walking day, your feet experience a totaling of hundreds of tons, which is basically the equivalent of having a fully loaded cement truck. 25% of the body's bones are located in the foot. There are approximately 8,000 nerves on the plantar aspect of the foot. That means that there's more nerves per square centimeter than any other place in the body. And it's kind of interesting because people's feet are the most sensitive, one of the most sensitive areas in the body. And that's definitely for a reason, as you can see the picture. The feet have approximately 250,000 sweat glands to allow our feet to sweat. That gets rid of some of our perspiration, and it's usually up to 1/2 pint per day, which is quite a bit. Some people come in and they do have this problem with their feet where they do have excessive perspiration, and that's another topic. Throughout history, people have had what they call a longer second toe. Some people may know about it as a royal toe, shepherd's toe, Morton's toe, or Greek foot. If we look at the slide here, this is actually one of the Roman statues from Italy, and it shows somebody having a longer second toe back before any modern technology was even around. So it shows that this is a genetic variant that people have had throughout the years. When people say they have a longer second toe, it's really not true. It's more a long second metatarsal. This arrow is showing the second metatarsal. The second metatarsal is normally longer in most people, but sometimes there's a genetic variant where we're born with a longer second metatarsal than it should be. Some people even have a longer third metatarsal, which is next to it, and the two bones actually protrude out, causing more pressure in the forefoot. Over many years of activities, the structures that surround these joints actually start to weaken and cause changes in our foot. We're going to talk a little bit about the anatomy of that joint. So this is a close-up of the anatomy of one of our metatarsal joints. We can see that it's a very complex area in a small area, and it's very compacted. We have the regular joint capsule, which is an envelope that actually produces fluid for the joint that lubricates the joint. We have something called the tendon sheath or extensor sheath, and that kind of holds down the tendons as we use them so they don't bow out. But the most important is something called the plantar plate. The plantar plate is a cartilaginous structure in our joint. And what it does is it acts as a pad for the metatarsal head to move back and forth. But what happens is over the years of constant pounding on the foot and constant irritation from those metatarsals being very long, what happens is there's a progressive weakening of the soft tissues causing a destabilization of the second toe joint. This can also happen, I've seen, in the third toe joint and also in the fourth toe joint sometimes. We'll go into this a little bit later. This causes a thinning degenerative change, which the plantar plate will thin out. It will actually sometimes tear. There are some people that do get this but have an injury, and it's called a plantar plate tear, which can lead to early or an earlier form of pre-dislocation syndrome. So what is pre-dislocation syndrome? It's basically a slow progressive shifting of the joint. When the joint becomes out of alignment, the joint structures then become stretched, they become inflamed, you start developing fluid in the joint, swelling, irritation. Usually I see people that this occurs in, it's mostly between the ages of 45 and 65 that it actually starts forming. But everybody's at a different level when I see them. They do have a grading system, but that's beyond the scope of this lecture. Basically, what I want people to understand is this is a slow progressive dislocation of your joint. Some people, if they wait long enough and don't treat it, they may even get a completely dislocated joint sometime in the future period. So what are the symptoms? Well, the early symptoms are pretty straightforward. What people start noticing when they come in is they'll tell me, you know, I've kind of noticed my toe drifting or actually elevating a little bit. I have swelling in the front of my foot or burning sensation in the ball of my foot. I have an achy feeling. Sometimes people actually get enough pain that the whole front of their foot will hurt. They can't discern whether it's the second toe, third toe, or fourth toe. Commonly, when this is early on, with the early symptoms, people are commonly misdiagnosed with something called Morton's neuroma, which is a totally different condition. That is a nerve entrapment that usually occurs between the third and fourth toes. But predislocation syndrome usually occurs around the second toe. It feels like you're walking on a marble. As we get older, our fat pad diminishes in the front of the foot. And then what happens is our metatarsals become more prominent, and especially if you have those longer metatarsals, you'll feel more pressure in that area. So you'll feel like you're walking on something. Patients will tell me that when they walk on a hard floor or a wooden floor at their home, it's very uncomfortable. They have to wear shoes in the house. When they walk onto carpet with a bare foot, they feel much better. So that kind of is some of the early signs of having predislocation syndrome. What are some conservative treatment that we can do for this once we know that you have this? Patients commonly will do some stretching exercises, which are very simple that I give them. Usually I'll have them stretch their toes down, because when we get inflammation of these particular joints, the body wants to dorsiflex or kind of contract. So as you get more inflamed, the toe wants to go up. So by stretching the toes down, you're stretching out some of those soft tissue structures that are becoming inflamed, which also help loosen the joint, period. Some people, when they do this, I tell them to hold it for 10 seconds, or you can do it throughout a half an hour, on and off, holding it 10 seconds down and then releasing, period. Some people I say do this while they're watching a half-hour show, Or you could just sit and do it anytime you want, multiple times, usually 10 or 15 minutes at a time, on and off for 10 seconds each. Another helpful thing to ice, and this is a very easy thing to do, is you get yourself a plastic water bottle, you freeze it. One thing about some of the icing elements that people use, some people use metal, which really is a better conductor of cold or temperature. So you actually have to be very careful because you can get yourself frostbite with that. You want something that's not very conductive. Plastic is not very conductive for thermal energy. So as you roll your foot on the water bottle, the ice in the bottle melts, but you don't get a very cold foot. If you're concerned about this, then you basically can wear a sock and do it as well. But the nice thing about the frozen water bottle is it helps reduce inflammation. It's easy to do. You can do it when you get home from work or while you're eating dinner. You could do it while you're watching a show or working on anything that you need on the computer. These are very easy things I show people to do in order to help reduce inflammation. This is also something that you want to do and get into the habit of if you're an exerciser. You definitely want to do some stretching before you exercise, and you always want to ice after the exercise. This helps keep any inflammation from the activity low so that it doesn't add to the already inflamed area. I also explain to patients that what we have to do is get pressure off those two bones or the one bone. And a very easy way to do that right away is to get some over-the-counter insoles. This day and age, we have Amazon. There's a lot of different places you can purchase insoles, but I find Amazon being the best because it has the best variety of insoles. One that you look for is always one with a metatarsal raise, and you can see that right here where the arrow is. And that helps push up behind the second, third, and fourth metatarsals to take pressure off of those. That will help with the constant pounding that those joints take. Some people like what they call a 3/4 length device, which is this device, or a full length device. The full length devices are better for like a gym shoe or an exercise shoe. The 3/4 length devices are better for people who want to wear them throughout the day in a semi-dress to dress shoe. You also can start taking anti-inflammatories. My favorite is Aleve, but whatever you normally take for inflammation, you can take. I find one Aleve a day for a short period of time, maybe 1 or 2 weeks, as long as you don't get stomach upset, and icing an insole as well as stretching in patients when they first get these symptoms. It may eventually go away, and sometimes you can keep this condition at bay or slow down the progression. Other things, if the pain doesn't respond to that, sometimes I do place patients on a course of prednisone. This is usually a graduated prednisone, which we have you take 2 pills in the morning, 2 pills at night for 4 days. Then you cut down to 2 pills a day for 4 days, and then 1 pill a day for 4 days. Some of the steroids out there, something called a Medrol dose pack, takes only 6 days, but the problem is you can get a rebound inflammation if you're on it too short. So I like to have patients on it for at least 12 days duration to get the maximum effect of reducing inflammation. And they do this along with the icing, stretching, and insoles. One thing that I will talk about is cortisone injections. And for this particular condition, it is really not recommended to do cortisone shots. Even though it can help and make you feel better for a short period of time, the problem is that cortisone injection can actually weaken the soft tissue structures around that joint and make this condition progress faster. Some patients have had injections where they told me their toe was pretty straight, just slightly elevated. They had an injection of cortisone, and 1 to 2 months later, their toe was overlapping their great toe. And I've seen this quite a few times. What cortisone will do is it does reduce inflammation and the inflammatory response, but it also can cause atrophy of our soft tissues. So therefore, the tissues surrounding that joint, stabilizing it, become weaker, thus progressing this faster period. Other things that can be done that are simple, if you have early problems with this, you can wear pads. There's something called a Boudin pad, which you actually can get on Amazon. And this actually holds your toe down. So when you walk, it actually puts pressure on the pad, which holds your toe down. This kind of stretches your toe while you're walking, so it's very helpful, and it keeps the toe in alignment. There's actually one with 2 loops that you could put over the second and third toes if you're having problems with that. Some people, they may decide to tape the toe down. This is a very common thing that can be done with some 1/4 inch tape. You just have to make sure that if you're diabetic or have circulation problems, you have to be very careful doing this because you do not want to cut off circulation to your toe. The other thing that we always talk about is shoe gear. And shoe gear is why I think a lot of people are having this problem now. Shoes many, many years ago used to have firmer midsoles. Now that people are more active and exercising more, the problem is there are so many exercise shoes or athletic shoes out there, but a lot of them do not have the support that you need because the shoes are not made as well as they used to be. So I always tell people when they go find a shoe, the one thing you need for sure is a firm midsole, and that's this area right here. This test you can do at the store when you go look at the shoe. You do what I call it the 1/3, 2/3 test. So basically, you want to push down on the heel of the shoe on a firm surface. You want 2/3 of the shoe to stay very firm and 1/3 of the shoe to bend, mostly at the toes. If the shoe is too flexible, it usually will just bend right in half. The problem with this is, as you are walking, when you lift your foot up or push off on your foot, the shoe will collapse in the back and your Achilles has to fire harder, which puts more pressure in the ball of your foot. That could cause more issues with predislocation syndrome and loading the second and third metatarsals, which get more pressure. What happens when you get to the point where you've tried all these things, your foot starts getting worse, or you have other medical issues such as bunions or other hammer toes? Well, when predislocation syndrome progresses, then you could start getting other deformities along with it. Some people do say that bunions and predislocation syndrome go together. That's not always true, and I'll show you cases at the end where it's not true at all. Bunions are a totally separate problem, but when you think about and when we discuss surgical correction, you do have to address other deformities. You can't just address the 2 deformities because other deformities can cause shifting of your correction. But what happens as this progresses, your toe will start moving up and moving over. It could shift to the right, it could shift to the left. It can just go straight up. It could pull the second toe up and also pull the third toe up, and eventually the 4th toe follows. So this can actually cause your foot to completely change over time. And this is an actual patient of mine right before I did surgery. And this patient, their main complaint was actually right here where the second and third metatarsal joints are. So what do you do when conservative treatment fails? You tried everything, you're having progressive pain, it doesn't get better. Well, when is it time for surgery? And that's always a question that people ask, when should I do this? Or, what's a good time? Well, the thing about having surgery, especially with the foot, is pain is the only true deciding factor. I'm an avid believer that if it isn't bothering you or isn't hurting and it isn't causing other issues, you can wait. Because the surgery these days, you can have, I do surgery in people's late 80s because they're still very active and still want to remain active, and they do very well. But you don't have to run tomorrow and have surgery just because you have some mild pain and discomfort that isn't getting better. Another thing that you have to think about is, does it affect your daily lifestyle? Is this something that's keeping you from working out? Is it harder to do your job? Is it harder to find shoes that are comfortable? These are all things that you have to take into account before you decide to do surgery. The last thing that I think is very important is you have to be mentally and physically ready to have a surgical correction, because having surgery is a mental and physiological issue that you have to get through the rehab, you have to get through some of the pain and postoperative hurdles. When you're definitely ready to do this, and I mean, usually most people will say, I've had it. I'm tired of dealing with this. My pain is beyond what I can control. I am ready to do this. I really feel that is the best time to do surgery for any type of surgery that is elective, talking about orthopedic surgery. This is not a life-threatening condition. It's something that's progressive. There is always a time that you can do it, but you can't always redo it. And I've had patients, unfortunately, rush into surgery and be misdiagnosed and have a neuroma removed that really wasn't a neuroma, and they come out of that surgery still having pain. So you definitely have to know what's going on. You have to be properly diagnosed. You have to have pain on a daily or monthly basis. It has to affect your daily lifestyle, and you have to know in your heart and in your mind that you are ready to do this and you're gung-ho about it, because those people do the best with any type of surgery. So I'm not gonna get too complicated, but I wanna kind of show you what this procedure is to correct this problem, because it can be corrected. And I do tell people, you can be proactive. You don't have to have extreme pain, but you have to have some form of pain. Just because your toe is longer, I don't do surgery because of that. Some people want what they call cosmetic foot surgery and toe shortening. I don't do that, because what happens is they don't have pain prior to surgery, but they will have after surgery because you're changing things. When something's not right and it's out of alignment and you fix it, it does feel better afterwards. So we're going to kind of show you right now what is actually done to correct this, and it can be corrected and you don't have to live with this. So the purpose of this surgery that we perform is to remove the deforming forces of the joint and reduce pressure under the ball of the foot. And once we do that, your pain goes away and it is permanent. Once we fix it, it stays that way. Thus, the deforming forces aren't there anymore and you don't get this problem again. Depending on the patient, some patients have a bunion associated with this. Some patients have more contracture of the toe associated with this. Some people have multiple hammer toes. It all depends on the patient and what bothers them, as where if they're having more problems with shoe gear, hammer toes, bunion problems, we do have to address those problems because they can interfere with what we're trying to achieve with fixing the pre-dislocation syndrome. So I always explain to the patient, you may have a bunion, but it may not be bothering you. But if I don't fix it, eventually it will bother you and you'll need a second surgery. I like to do surgeries where we kind of correct everything, and we will show you a case like this where we realign the front of the foot so that it's sound and your foot functions the way it properly should. The goal is to reestablish what we call the metatarsal parabola, and that's an arc of the metatarsals, and we'll talk about that. So in the end, there's even distribution of pressure under the ball of your foot. It's not just under those 2 bones or that 1 bone, it's under all 5 metatarsal bones. So over here on this diagram, this is your metatarsal bone. This is what it looks like from the side. This is your toe base and one of your phalanges. So you're looking almost at the side of the foot. You're not looking straight on. And what we actually have to do is, when we say shorten the bone, we have to cut the bone in a certain way where we use an oscillating saw. And what we do is we cut the bone, and then with this arrow, we're gonna, once it's cut, we shift it back. But you could see the metatarsal is also going upwards. So as we're shifting it backwards 3 to 4 millimeters, we're also actually pushing that bone up. So we're elevating it and shortening it. Once we have it in that position, then I usually use 1 screw. They're showing 2 screws here. And then we remove the little excess bone. We're not getting rid of your cartilage. So what we're doing is we're shortening the metatarsal, and then this decompresses your joint. So imagine your toe being up here, and the reason it's up here and there's more pressure down here is the toe is pushing down on that metatarsal. Once we do this procedure, it allows that toe to come back down in front, and we decompress the joint. Some people, if they have a hammer toe, which usually with more severe predislocation syndrome, they have a hammer toe associated with that 2nd toe joint or that 3rd toe joint. I prefer to do a fusion of that joint because a lot of times that hammer toe is not real functional. So it will move up and down once we fix it, but we need to fuse that main joint to keep it straight so that it doesn't reoccur. An older procedure was something called an arthroplasty, where they would just remove a portion of the bone but not fuse it. Some doctors do it differently. Some doctors like to use K-wires, where they put a wire down a toe. That does lead you to a longer postoperative period. It's all based on what the doctor prefers to do or what they're trained to do. I have actually learned more to do the implants, and have been doing that for many years. And they work very well because it's nice because patients can get into a shoe a lot faster than they used to. So what we want to do is we actually take a little bit of bone from each portion of that joint. I put a little implant in, make a little hole here, and then we basically connect the 2 bones together, and they will heal together, fusing the joint. And this is what it would look like afterwards. So now we're going to go over a couple case studies. And, like I said, I'm going to show you a simpler case of what some things that can happen to a patient when they have predislocation syndrome. So this is a middle-aged patient, and the red line indicates how far up that 2nd metatarsal is. You could see the other metatarsals are a lot lower than that red line. And that red line goes through the base of his great toe. Now, you could also see on this patient that he doesn't have a bunion deformity, but you could see that toe drifting, and you could see that toe becoming hammered. You also can see on his x-ray that he actually had a previous fracture or stress fracture on his 3rd metatarsal, which may have shifted back, and that was probably due to the fact that he had a longer 3rd metatarsal and he had too much stress on it. So the patient came in, and their main complaint was pain around this area. And he had tried different types of insoles. He tried anti-inflammatory, stretching, very active, and it just didn't work for him. So he came in seeking surgical correction. So if you look on the other side, this is the post-operative side where I just put the red line. And now you can see that we've shortened that 2nd metatarsal. This is where this arc, the metatarsal parabola here. So now each bone should be a little bit shorter than the next. When I go from their preoperative film, if I go through here with the arrow, you can see it goes through this bone and then goes over these bones. So that shows me that his metatarsal is a lot longer here. So that predisposes him to this condition. He also had the contracted toe. So what I did is I shortened the bone, fixated it with a screw, and then we went to his toe, took a little bit out on each side of that joint, and put the implant in to fuse it. And then sometimes on certain patients, I go a little bit further. This procedure, called the Weil osteotomy, has been around for many years, but one of the main complications can be a floating toe. So your toe could actually still be kind of up in the air after this procedure is performed. A lot of people do have what we call redundant skin underneath that joint. So what I do is I call it a tummy tuck of the toe. It actually is removing some of that redundant skin and pulling that toe down at the same level of the other toes. Once that heals and I remove excess skin, it will stay that way and it doesn't float. Most people who had floating toes didn't have pain anymore, but their toe was up in the air and they had problems with shoes. So this is something that I kind of developed as part of my surgical procedure to help keep people from having a floating toe. This is probably one of my worst cases of a patient who had a very complex predislocation syndrome. And believe it or not, this patient was in his mid-70s, had lived his whole life kind of with his feet becoming more deformed as time went on, but he didn't have much pain. As he got a little bit older, when he was about 65, he said he started noticing the toes drifting. Then he stated he started having a lot of pain in the ball of his foot. He also had a bunion deformity, but even at this visit, when I took his first x-ray here, he didn't have much pain in the bunion. But looking at the situation, you can see how other people can have different deformities that still can affect the proper realignment of the forefoot. So everything usually has to be addressed. So when I do an exam on a patient, I go through everything with them. I check their toes, I check the bunion, I ask if they have pain. It's not that he never had pain at this joint, but it wasn't that bothersome. And he was able to find comfortable enough shoes. His biggest issue was pain in the ball of his foot when he walked. And he was still very active. He played golf. He liked to go walking a lot and ride bikes. So he was at the point also where he had tried multiple things, went to multiple doctors. A couple doctors told him there was nothing that they can do for him, and he was very frustrated. So he came to me and I explained the situation to him, and that's part of the surgical pre-op is you want a doctor that's going to really sit down with you and take time and explain things to you and educate you before you ever have the surgery. It's very important that you become educated, that you know what your condition is, what is going to be done, what are the possible risks involved, and what is the postoperative course. We also give people a packet that has all that kind of reiterated so that they can read that, and if they have any questions, they contact us before the surgery. You as a patient, it's very important to make sure that you're not being rushed through your surgery. It doesn't matter who's doing it. It's very easy to do a surgery. It's not easy to undo a surgery. And some people don't know what to expect, and they go in expecting one thing and come out with another thing. So it's very important to understand exactly what's going to be done. So now we're going to show you. You see the red line, and you see that red line is way above all the other metatarsals. His metatarsal parabola shows that he has a longer second and third metatarsal, but his second metatarsal is the longest. So I explained to him that he will have to have his bunion fixed. We will have to fix this hammer toe, and we will have to do a little work on his third toe, which was coming down and causing him problems. I'll also show you his lateral view in a second, but now this is the postoperative area. So you can see everything can be corrected. This is actually his 2-week postoperative x-ray. And here now you can see where each metatarsal is where it should be. and we've corrected his bunion, and we've corrected his toe and his other toe, and everything is sound. This is going from an abnormal looking foot to a normal sound foot, where the weight distribution is across the whole ball of the foot. And now you can see that this line from lowering or shortening this bone has gone down to almost the base of his big toe, which is where it should be. Now we're going to show you what his foot looked like from the side. This is his second toe up in the air. And like I said, we also performed that little tummy tuck of the toe after his surgery, so that when he's done at the end, you could see his toe is up in the air. Now you can see his toe is nice and flat, and it's even with the other toes. And that's what I always look for in a surgery once I'm completed. I always check at the end to make sure. Some people need that extra little tummy tuck, some people don't. The other thing that you can see is this implant that I use. This is called a Digifuse implant. It's made of, all the hardware I use is titanium. Usually they do not have to be removed, but there is an occasion where sometimes the screws loosen or they need to be removed based on your bone density, or they are more prominent. This patient, actually, this was his post-op 2-week view. You could see he has very little swelling here as compared to his pre-op x-ray. So the patient was actually back in the shoe this day after that much surgery. So what are the specifics of this condition, and when and why do you have surgery? Well, one, when you have the surgery, it's done as an outpatient. Very rarely these days now, people are staying in the hospital for any surgery. Actually, at our surgery center, we're one of the top surgery centers now for doing outpatient hip and knee surgery replacements. We're also starting to do minor back surgeries and disc surgeries, which patients go home the same day, they're rehabbed the same day. Foot surgery's been like that for quite a few years. And the nice thing about this is it's an outpatient setting. It's a faster progress or procedure. You're not waiting around in a hospital where there's other possible areas of infection or disease. Usually I do this under sedation, which is basically giving you an IV. They give you medication called propofol that makes you sleepy, but it doesn't depress your breathing to a point where you're not going to breathe. So the anesthesiologist will keep you breathing throughout that procedure, but will be giving you something that you're not really aware. It's very similar to having a colonoscopy. Some people, if they just have 2 bones that need to be shortened and they're younger, they may decide to go straight local, and we can do it that way, where I just numb up the area and we do the surgery. It's like going to the dentist. You hear a little burring, you hear a little drill, you don't feel pain, and we make sure that you're definitely numb before we start. The other nice thing is most of these procedures now, because we use internal fixation, you can actually ambulate on your foot the same day. So people are usually up and walking in the same day. You may be in a surgical boot or a surgical shoe, depending on what we do. So patients that have more surgery done of the forefoot, they will definitely be in a boot, but they'll be able to walk on it. Depending on your age, I sometimes give people crutches or a walker to stabilize you. It's not so that you have to walk not weight bearing, but to walk where you're not going to feel like you're going to fall over because one side's higher than the other. I'm very, very conscientious about pain. I do not believe in this day and age, with all the wonderful technology we have and pain management, that anybody should have horrible pain after surgery. It really should not happen. And there's different pain pathways, and that's a whole different lecture. But postoperative pain is usually minimal. When I say minimal, you're going to have some discomfort, but you're not going to be crying out in pain. Very rare does that happen. And it's usually patients who either can't tolerate oral pain medications or can't tolerate anti-inflammatories. When I medicate my patients, I do numb them up with a medication that will keep their foot numb for up to 9 to 12 hours. The pain cycle starts immediately once we start the surgery. The brain is actually aware of the fact that we're cutting into your foot and changing things and causing surgical fractures. So in your brain, you're experiencing pain, but because you're numbed up, the local area does not feel pain. But when that local area wears off, your brain will feel pain, and that's when people experience pain. The big mistake that most doctors make will tell you, when you start having pain, take your medication as directed. The issue now is you have to pre-medicate. So I keep you numbed up long enough where you can get the medications into your system, and we recommend taking them around the clock, usually for the first 24 hours. So you take one pill of a narcotic and one pill of an anti-inflammatory, or if you're able to take those, every 6 hours for the first day, even if you're not having pain, because your brain still perceives it. All you're doing is blocking the 3 different receptors in the spinal cord before that area wears off. And that is the key. And most patients come in, actually the last case that I showed you, he came in, he said he barely had any pain post-operative. With the way I do things, patients are seen back at 1 week after surgery. Usually I tell people to take off work for at least a week. If it's your right foot, you can't drive for 2 weeks. Naturally, the skin itself takes 2 weeks to heal. So no matter what kind of surgery you have, whether it's minimal incision, whether it's fully open surgery or minimal surgery, you still have to allow the skin to heal, and it still takes 2 weeks no matter what. So in order to get back comfortably in a shoe, it's usually in about 2 weeks. Once we see you back at 2 weeks, we take out your sutures. I usually sew most of the patients underneath their skin when it comes to the bunion, but the sutures in the area for pre-dislocation are actually outside of the skin. And I don't use absorbable sutures on the skin because they don't absorb fast enough or dissolve fast enough, so we end up having to pull them out anyway. So I use something called purling, which is what most of the plastic surgeons use, and it's very non-reactive. So we're trying to make sure that everything with your surgery and pain-wise, scar-wise, ambulation is a lot smoother than things used to be. So basically, the other thing is people ask me, when can I exercise or when can I resume certain activities? Most of my patients at 2 weeks will be able to drive a car. They'll be able to go for walks. They'll be able to possibly ride a bike or ride a stationary bike and do elliptical if they're able to get into a gym shoe. Things like high impact activities, running, jumping, climbing, usually don't occur until 6 weeks, but that doesn't mean you're not active. Most patients are fairly active with their everyday lifestyle at 2 weeks. People ask, will it come back? Well, the recurrence rate for most forefoot surgery is about 1 to 2% if the right procedure is done. And that's the one thing that I always go back to. Make sure, if you're not sure about one thing that a doctor tells you, get another opinion. 2 heads are better always, and 3 heads are the best. So sometimes you get another opinion if you're really not sure. Sometimes you get a doctor that really explains things properly, you feel confident, and probably that's the doctor that you're going to go with. In this day and age, especially with everything going on, an active lifestyle, there's no reason people should live with chronic pain in terms of the foot unless it's some kind of condition that there's no control over. That ends my lecture. I hope you enjoyed that, and now we are going to be open for questions.
All right, Dr. Solway, thank you very much. And we do have a few questions coming through. I'm going to kind of combine a few of them to start.
Okay.
After having an exam to diagnose predislocation syndrome, do you have to have diagnostic testing to confirm that? And I'm going to add that to another question where someone was trying to understand the difference between predislocation and neuropathic pain. And would an EMG test help to determine the difference between the two? So it's kind of 2-in-1 question there.
Yeah, the thing about predislocation syndrome, I'm very familiar with it. So when a patient comes into my office, I kind of know beforehand it's probably going to be that. There are diagnostic tests that you can do. Like if, let's say you had an injury to your forefoot, which some people have, and like I said, the average age is 45 to 65, but younger people can get this. They can have an injury, tear their plantar plate, and they could develop early predislocation syndrome. So in order to diagnose that, sometimes we send them for a diagnostic ultrasound, which actually is a better test because you could do it live where you can move the joint versus an MRI. MRI is very good, but I prefer ultrasound because it's interactive. We can see what's going on, and it actually is less invasive, where you don't have to sit there for 45 minutes. And if you have a bad back and you can't sit still, it's a very easy test to do where you sit up. The ultrasound your foot, takes different pictures, and basically sends us the pictures. So yes, there are tests that you can do. There's also manual tests that I can do in the office called the luxation test to see if you have loosening of the joint and pain with that. A lot of problems occur with this in terms of people being misdiagnosed with Morton's neuroma. And Morton's neuroma can cause forefoot pain and nerve type pain, numbness and tingling in the toes, but actually so can predislocation syndrome. When the joint capsule gets very inflamed, your nerves run on each side of that. So as that joint becomes more swollen, the nerves get pushed on. So people think they have numbness in the second, third, and fourth toes. That's not typical for a neuroma. The other thing is you have to also, going back to the other question, is this something called neuropathy? And it's completely a nerve issue. There are some patients that come in and say, both my feet are numb and tingly all the time in the whole front of my foot. Some of these patients will have a condition that is associated with neuropathy, like diabetes. Very rarely do we see alcoholism now, which people get neuropathy from that, or syphilis. But diabetes is the #1. Some people we're now starting to see with significant increase in numbers of people getting something called idiopathic neuropathy, which is a neuropathy of the small fibers that you don't have to have an underlying condition. And we're seeing more and more people have this. We don't know why. They're doing studies on it. But yes, if you're concerned about it being a nerve versus bone, definitely you can get an EMG nerve conduction study. If you're more concerned about it being predislocation syndrome versus neuroma, you can get an easy ultrasound, because the ultrasound actually will show if you have a neuroma, because it actually can detect it. So we can detect whether it's the joint or if it's a neuroma, or both. And some people even have both. So that's usually the answer to that.
That makes sense. Awesome. Thank you very much. That makes a
Yes.
lot of sense. Okay. Is this something that can be acute as well as a chronic? It sounds like it's often more of a chronic thing, but I suppose if someone's injured, it could then be an acute situation that someone would come to you with, correct?
Yes, on average, the average person that gets this will come in, they may have had it already 6-7 months.
Got it.
To me, anything over 3 months is considered chronic. So the question is acute. Well, some people, the reason why they don't come in soon enough is they think it's going to go away. And that's the most, human nature thing that people do. Plus, there's all these, gadgets and things that you can try first, some of them which I showed you, that people try, and there's nothing wrong with that. I usually like the patients that do come in, they may only had it for like 1 or 2 weeks, but I'm able to educate them that, yeah, this is early predislocation syndrome. If we do this, this, and this, we may be able to stop the inflammation and slow down the progression. The one thing I have to let people know with this lecture is this is progressive. Even if it slows down, eventually the majority of people that I see end up having some type of surgery because it eventually gets to a point where it's not controlled. There is a small population, I would say it's maybe 10 or 5% of people that actually luck out, live with it. They don't have much pain, and they wear, like, we get them an orthotic that seems to really help, and they're happy with that. Some people physically can't have surgery, so we try to do things that will help it. Yes, I will give a cortisone shot to someone who's a little bit more debilitated. They can't have surgery. They're in pain. We have them in a special shoe so that can accommodate their toes, but we would give them a cortisone shot knowing that they're not going to be able to have surgery.
Gotcha. That makes sense. Does this ever happen in people who don't have the elongated second metatarsal, aside from someone who had an impact injury or something like that?
It can. People can get this, but usually, in most people, I would say the majority of the population does have a longer second metatarsal. The difference is this genetic variant is longer than it should be. Yeah. So people still will have, in certain foot structures, a longer second metatarsals. They're not actually what I would consider pre-dislocation syndrome patients, but yes, they can get this as well. Some people get atrophy of their fat pad. It could also be related to the types of activities they did their whole lives, playing tennis or a lot of running, jumping type activities.
So for someone, you mentioned that it's genetic. So for someone who does have that elongated second metatarsal, which makes that second toe longer, aside from proper footwear, doing the squish test, are there things that those people can do to prevent this from happening over time?
It's interesting. I mean, there really isn't something that you can do to prevent it. You know, unfortunately, it will occur. I know I've had patients that came in early and I saw them 5 years later and it progressed. They were doing good for 5 years. This is something that isn't always going to happen on somebody that has the longer second metatarsal. So it's based on, it's a lot of different factors. So the one thing you have to understand in medicine is, and especially when it comes to orthopedics, there are so many extraneous factors that go into why you're having your condition that either make it worse or better, and you can't control all those factors. So to say, yes, you can prevent it, no, it's not something that you can prevent really, but you can address it. The sooner you address it, the longer it may take for you to get to that point where you may have to have surgery.
Got it. And if it happens to one foot, what are the chances of it happening to the other foot?
That's a very good question. A lot of people ask me that question. A lot of times it usually occurs in only one foot. The reason being, just like we have a dominant hand, we also have a dominant foot. The difference is our dominant foot isn't really the foot based on what we have as our dominant hand. So usually the dominant foot is the one that's going to start having issues. That's the foot that you use the most. Some people, if you're a cashier and you're standing all day, you may put a lot of pressure on that one foot. I have a few pharmacists that have this because they're on their feet all day long and standing, and they stand a certain way when they're on the phone. It puts more pressure. Or if you're an athlete, you use one foot more than the other. So it can occur in both feet. I've seen a lot of patients that get it in both feet because both feet are somewhat symmetrical, but both feet are never really the same size. Even though you think it is, one's usually a little bit bigger than the other. And you may be using your one foot more than the other. So that would predispose you more to getting it on that foot first. But I do see people that get it in both feet, or they get it in one foot, and then eventually they get it in another foot later on in their life.
Gotcha. Thank you. All right. And someone asks, can you do the conservative exercises even if you haven't been diagnosed? What's your recommendation on that?
You can do the it's nothing wrong with stretching. It's very important. Our biggest problem, I think, a lot of people, they work hard and what they call play hard. So basically you get home from work, you eat and you run out and you do your workout, or you go to the gym, or you go on your bike ride. But a lot of times as adults, and even more so in children or young adults, you don't stretch. And this is something that when I was with the Bulls, of course, these players, they make their livelihood on playing. If they can't play, they don't make a livelihood. So we don't do that. So we have a tendency not to do extra things to keep us in shape. And that's one thing that I always try to tell patients. You want to kind of make those things a habit. So if you go, or if you're a runner and you have certain issues you want, like plantar fasciitis or heel pain, you want to stretch the gastroc and the plantar fascia. If you have problems with pre-dislocation, you want to do the toe stretches. Always do it before activity, and then you also want to ice after activity. When Michael Jordan, you'd see him on the sidelines icing during the playoffs, it wasn't because he had an injured knee. It was because they were trying to keep the inflammation down from when he was playing so that he wouldn't aggravate things that were already inflamed, which every player has something. So that's why I tell people it's good to make it a habit. Ice baths, icing your foot with the rolling water bottle is good. It's relaxing. You can get yourself foot massages, different things. But these things are all good. They're not going to harm you. They're only going to help you. So I do recommend doing things prophylactically.
Wonderful. Thank you very much. And we have gone past 8 o'clock, so I will not keep you any longer.
All right.
Everyone, thank you for joining us tonight. I know we had a few more questions, but I always try to be respectful of the doctor's time and of everyone else's time. Dr. Solway's information is on the screen. Feel free to reach out to him. If you've already had first and second opinions, he might be someone to see for a third opinion. Thank you, Dr. Solway, for your time and for discussing this very important topic. Maybe we can have you back to discuss some other foot issues as well down the road.
Most definitely. Thank you.
Wonderful. Thanks, Dr. Solway. Thanks, everyone. Have a great night.
Yep.